Julie, we can't hear you for some reason. Did it unplug? Apologies, everyone. Julie's using a new microphone tonight.
Can you hear me now, ladies and gentlemen? I do beg your pardon. I was trying a new skill in order to help prevent dementia, because learning new things is one of the strategies we'll be discussing tonight, but I will use my voice and not my microphone. So my apologies, and welcome to this Wolper Wellbeing webinar on reducing your risk of dementia, and we're going to be offering you practical advice. Tonight's webinar is hosted by Wolper Jewish Hospital, Friends of Wolper, and our partner for this webinar is Dementia Support Australia. My name is Julie McCrossin, and it is my pleasure to host this webinar and our panel discussion as well. I'd like to begin by acknowledging that we're broadcasting to you on the land of the Gadigal people in Sydney, and to pay our respects to elders past, present and emerging. As a few more people are joining us, I can see the numbers growing. I'll just give you some quick housekeeping. Your questions are welcome in the chat, in the Q&A session. If you could confirm that, Nat, that I'm saying the correct thing. Your question, yes?
Yes, correct.
Yes, thank you. Your questions are welcome in the Q&A that you'll see on the bottom of your screen, and you can give them to us all the way through the broadcast. And thank you to everybody who's already sent us quite a number of questions by email. Just remember that we can't see or hear you, so the Q&A is the only way that you can send questions to us. Our question moderator is General Practitioner Dr. Lena Safro. She's watching all your questions coming in. She has your earlier questions, and I'll bring her onto the screen throughout the evening to bring questions from you, the audience. I do want to also remind you that we do record this webinar, so you will be able to watch it again on the Wolper Jewish Hospital website. And of course, we're going to try and answer as many questions as possible, but we can't give individual medical advice. Now, ladies and gentlemen and everyone, this evening, before we begin our dementia discussion, I'd like to welcome Dr. Lena Safro to make some opening remarks about the tragedy in the Middle East. Lena, as I said, is a general practitioner practicing in Sydney and in rural New South Wales, and she's also the chair of the Education Subcommittee of the Australasian Menopause Society. Welcome to you, Lena.
Thank you, Julie. We're in mourning this week for the 6 innocent executed hostages: Ori Danino, Kamel Gat, Hirsch Goldberg Polen, Alexander Lobanov, Almog Sarusi, and Eden Yerushalmi. We grieve their deaths, we mourn with their families, and we honor the light that they brought into the world, although their lives were cruelly cut too short. Their absence is a sorrow that sits in all our hearts tonight and for all the days to come. May their memory be a blessing. Tonight, we also remember and honor the incredible bravery and sacrifice of our soldiers, police officers, and all the innocent victims of senseless terror. Our hearts ache for the families who have experienced loss. We pray for the safe return of the hostages, the end of all loss of innocent life, and we hope for peace.
Thank you very much, Lena. Thank you. Well, if you're joining us for the first time tonight, a special welcome to you. Wolper Jewish Hospital is a specialist medical rehabilitation and palliative care hospital in the eastern suburbs of Sydney, and Wolper welcomes people from all cultural and religious backgrounds. And as you know, I hope our topic tonight is reducing your risk of dementia. And I'd like to begin by welcoming our partner for this webinar, Holly Markwell from Dementia Support Australia, to make some opening remarks. Welcome.
Thank you very much, Julie, and thank you to Wolper for including me in this session. It's really important. Dementia Support Australia is a free, federally funded government service that I would imagine, in fact, that you may be here because you have a family member who is living with dementia and you are motivated to learn what you can do to reduce your risk. What we're here to do is to help when a person is living with dementia and their behaviour changes. We have, as I said, it's a free service. We have a dedicated 24/7 helpline. And behind that helpline sits a team of incredible specialised dementia consultants who really work with a practice of understanding what the behaviour is and what might be causing the behaviour, and then tailoring individualized strategies, and they are the absolute gold standard. It's not pharmacological, and I know that Henry will back me up on this. It is about non-pharmacological strategies which are tailored to the individual, and that's exactly what we can do to walk beside you to just hopefully make life that little bit easier, both for you if you are a family carer, and importantly for that person who's living with dementia. So again, thank you very much for including us in this really important webinar.
Thank you so much, Holly. Now, just before I bring our panel on, everybody, and we begin, we're going to have a quick live poll so that our panel members can learn a little bit more about you, the audience. We've got 5 questions. Essentially, I read the question, you answer it on your technology on your screen, and then I read your answers immediately after. So I'll ask Nat, our technical whiz, to put up question 1, please. Question 1, your gender, male, female, other, prefer not to say. If you could click your answer, please. So 30% of our audience tonight are men, and 68% are women, and we have one other and one prefer not to say. Thank you. Our second question goes to our age. Is your age under 40 years of age, 40 to 60, 61 to 74, 75 or over? Please choose your answer. % of our audience is under 40, 9% between 40 and 60, 40% 61 to 74, and half our audience is 75 or over. A huge welcome to you. Our next question is on prevention. Do you have any of the following habits? Mark all relevant options, so you can mark more than one. Smoking, alcohol consumption, more than 14 standard drinks per week, regular weekly physical activity of at least 2.5 hours of moderate exercise or 75 minutes of vigorous exercise per week, 7 to 9 hours of sleep daily. You read books, play word games, do puzzles such as crossword puzzles and Sudoku, make healthy food choices, for example, at least 3 servings of vegetables daily, or none of the above. So mark as many as you wish, please. No smokers. This is called deaf sign clapping. And if you can probably see my hands on either side of the screen. Alcohol consumption of more than 14 standard drinks, 4%. That's per week, obviously. Regular weekly physical activity to the requested rate, 80%. Brilliant. More deaf sign clapping. 7 to 9 hours of sleep, 69%. Read books, 64%. Play word games or puzzles, 58%. Making healthy food choices, 72%. None of the above, 1%. And thank you very much to the honesty in the answering of those questions. Our next question goes to health status. have you had or do you have, and you can click as many as you like, consistent high blood pressure, hypertension in midlife between 45 and 65, type 2 diabetes in midlife, 45 to 65, high cholesterol or LDL lipoprotein, atrial fibrillation, obesity in midlife, 45 to 65, depression in mid or later life, traumatic brain injury or repeated head injuries, hearing loss, poor vision, social isolation or loneliness. So click as many as you wish. Consistent high blood pressure, 31%. Type 2 diabetes in midlife, 7%. High cholesterol or LDL lipoprotein, 45%. Atrial fibrillation, 7%. Obesity in midlife, 19%. Depression in mid or later life, 21%. Traumatic brain injury or repeated head injury, 2%. And we just have one last question.
Oh, you forgot 3. No.
Oh, I do beg your pardon. Hearing loss, 44%. Poor vision, 21%. Social isolation or loneliness, 11%. And our final question, family history. Have you been diagnosed with dementia? Has someone in your family been diagnosed with dementia? Obviously, you can tick both if they apply. I think we'll see the answers. 2 people with us tonight have been diagnosed with dementia, and a very special welcome to you. And 98% have someone in their family diagnosed with dementia. Look, thank you so much for answering those questions. It gives me pleasure now to welcome to the screen our panel for the night. I want to, first of all, welcome Professor Henry Brodaty, who I want you to see. He's waving to us. I wonder, Nat, if you could put him on full screen if possible, just so people can see what Professor Brodaty is doing. Professor Brodaty has been exercising throughout that poll. If you could invite the rest of the panel on, Professor Brodaty, you are exercising. If you could come over to your computer. And could I also welcome Scientia Professor Kaarin Anstey, Geriatrician Dr. Anita Nitchingham, and also Keri Kitay, who is the daughter of a mother who was diagnosed with Alzheimer's, and she's the author of a book, The Long Goodbye, Lessons on Humanity from the Grips of Alzheimer's. Welcome to you all on our panel, and a special welcome to Professor Henry Brodaty. I'll introduce you in full as I ask you to speak, and obviously the focus is on the reducing our risk of dementia. Professor Henry Brodaty is also a Scientia professor, Professor of Aging and Mental Health at the University of New South Wales, co-director of the Centre for Healthy Brain Aging at University of New South Wales, and a psycho-geriatrician involved at Prince of Wales. A big welcome to you, Henry, and thank you for beginning by exercising and agreeing to stand throughout. If you could turn your mic on, I think you were just wanting to begin by noting the passing of our beloved Alan Shell. You're not quite turned on yet, sorry.
Alan Shell and I basically grew up together. I've known him for most of my life, and he worked with me for 15 years. And for me, it's the first, I've done a few of these Wolper webinars and in-person ones as well. And it's the first time Alan hasn't been sharing it. And so I really miss him, and I'm sure we all do, and acknowledge what a wonderful human being he was, a great doctor, and a great promoter of healthy living.
Thank you so much, Henry. And for those of you who may not know, Dr. Alenshaw is a beloved general practitioner with enormous interest in healthy aging and age-friendly, dementia-friendly social environments and so much more. And he was an instigator and a host of our sessions and the question moderation for many years, and who recently passed away. Let's get to some basic things on the table before we go to our first lot of questions. Can you give us a definition of dementia and just give us the basic types of dementia?
So it's pretty easy. It's just two items for the definition. One is declining cognition, and that declining cognition interferes with daily life-to-life function. So we all have some memory loss, forgetting people's names and things. But if it's starting to interfere with day-to-day function, then and the memory problems can be confirmed objectively, then that's dementia. And it's simple as that. And then there are many, many sorts, maybe 100 different types, all defined by different pathologies happening in the brains. So different ways the brain degenerates or is damaged in some way. So Alzheimer's is the most common. And the second most common is vascular dementia. There are problems with the circulation. It may be just a gradual clogging up of arteries, or it may be a stroke or even a hemorrhage. And then the other two big ones are Lewy body dementia and frontotemporal dementia. And there are many, many other sorts. And you asked questions in the poll, Julie, about alcohol. A little bit of alcohol is okay for the brain. Heavy drinking is bad for the brain. Head injury, of course, is bad for the brain. And we see a lot of publicity about that with football players and boxers now.
And could I ask you, you sometimes hear about early onset dementia and late onset dementia. Could you just explain that difference for us?
Yes, sometimes it's called young onset dementia rather than early onset, because otherwise it's ambiguous. Early onset is early in the dementia, but it's early in age. And so most people now call it young onset dementia. By definition, that's under the age of 65. So the majority of people develop dementia as we grow older, and the rate doubles every 5 years after about the age of 60. So it might be 20% of people over 80, 30% of people over 90, 100, 50% of people over 100. And the rates are much smaller as you get younger, of course. But there are almost 30,000 people who develop dementia before the age of 65 in Australia. And there are different problems, and the mix of dementias is quite different. The more frontotemporal dementia there, and some of the alcohol and head injury dementias too, and some of the infections in the old days with HIV was a major cause of dementia too.
And you mentioned it's objectively diagnosed, or words to that effect. Could you tell us in what circumstances should someone go along to their GP and say, I think I might need an assessment. I think my memory loss is more than normal?
Well, if other people are noticing, if it's not just memory, but it's interfering with day-to-day life, or forgetting words, getting lost in familiar places, finding it difficult to grasp concepts. In other words, if there's a spread of affecting different domains of types of cognition, other people are noticing and it's interfering with life, definitely go along. It's possible that the cause could be reversible. I don't see many of those, certainly by the time they get to see me in a specialist clinic. But there are things like that can be easily diagnosed, like a low thyroid or a low vitamin B12. Sometimes tumours can present with dementia. So there are many causes, and it's always worth getting checked out. Objectively means getting tested on your cognition. You might remember the year that ex-President Trump stood up and held up his test score. He did something called the MOCA, the Montreal Cognitive Assessment, and said, I got 30 out of 30, so I'm fine. Yeah. And that's probably one of the most common tests used by GPs and me too. Yeah.
Just before I introduce another one of our panel members, one of your areas of research is behavioural and psychological symptoms of dementia. Can you tell us just a little bit more about the psychological?
Yeah, and that's the area that Dementia Support Australia supports, with Holly Maxwell's been talking about. So most people with dementia will get some behaviour or psychological symptoms. It could be becoming agitated or aggressive, or losing their filter, their inhibitions, or sleep becoming disrupted, or people getting depressed. There's 20% more get major depression during the dementia, Anxiety is quite common. Some people get delusions or hallucinations, and delusions are quite common. So, for example, if I'm having dementia, I might try and hang on to my valuables because they make me feel secure. And so I hide my jewels, but then I can't find them because I've forgotten where I hid them. And so I immediately accuse people of stealing them. And then that goes on and on. So delusions of theft or infidelity are quite common. And in certain sorts of dementia, like Lewy body dementia, people have quite striking visual hallucinations, seeing people in the room or animals on the walls. And often that's more distressing for the family than it is for the person.
Henry, we're going to talk a lot about the practical things you can do to reduce your risk. But I guess the first big question is, how significant is genetics? So how many modifiable risk factors are there? And are there some we actually can't change for ourselves if they're in our genes?
Well, the genes are set. We have a blueprint for our life, but how they express themselves is different. And this is called epigenetics, because how we live our life can affect how much the gene acts or how it's modified in some way. It was estimated, well, in July this year, there was a landmark paper that came out from the Lancet Commission, led by Jill Livingston, and it now says there are 14 environmentally modifiable, potentially modifiable factors that account for 45% the risk of all dementia. And you've listed a lot of those in your poll earlier, and there are several more as well. And these are things we can all do something about. And I'm amazed at this audience. I think it was 90-something% doing regular exercise. That's fantastic. And this is a very healthy group. It's very impressive to see that the message from Wolper, because I've talked about this very issue, has really been getting out there and is making a difference.
I'm going to come back to you, Henry, to talk about rehabilitation or reablement, and also about some new medications on the horizon. But let me now welcome another Scientia professor, Kaarin Anstey, from the School of Psychology at the University of New South Wales, and director of the UNSW Aging Futures Institute. And I know you have a big focus in your research on cognitive resilience, as well as risk assessment tools and intervention. So a big welcome to you. Can you explain what cognitive resilience is?
Yeah, so we're interested not in just the risk factors, but there are some people who have the genetic risk for Alzheimer's disease, for example, but who don't develop it or develop memory problems very, very late in life. And so we're also interested in trying to understand what is different about those people who are not declining despite having, a clear risk factor. So that's what we mean. And then we look at the different lifestyle and other factors that differentiate that group.
And do we have any answers at this stage, or preliminary hypotheses that look promising?
Well, there hasn't been a lot of studies published, but the few that have been published have all tend to show there are gender differences here. So in, physical activity with men, it seems to be men who do more mild physical activity are more protected, and women who do more cognitively stimulating activities are protected. When we're looking at genetic risk. And there's other ways of defining resilience. So you could also have adversities related to your life events that happen to you, or having had a stroke. Why do some people develop dementia after a stroke, so post-stroke dementia, but other people don't? So in any situation like that, we can ask not only what are the risk factors, but what is going on with the people who are not declining. And so we think that's a way of discovering even more about how to prevent dementia ultimately.
You say, as I understand, that it is possible to delay onset, even if you do have a significant genetic predisposition.
Yes.
Can you explain how you could do that to delay onset?
Yeah, so what the research shows is that in people who have with the main genetic risk factor for Alzheimer's disease, it's actually very common. So 1 in 4 of us actually have the apolipoprotein 4 E4 allele. But what we know is that even if you have the genetic risk, if you adopt a healthy lifestyle and manage all of the risk factors, which I think we're going to talk more about tonight, you have a reduced risk of developing dementia, and that's been shown in big systematic reviews where they've synthesized information from many, many studies. But also, you delay the age at which you start to decline, and then you may die of something else, or you'll have what we're really interested in is what we call compressing morbidity. So making the time that you have cognitive problems and cognitive impairment as short as possible through optimizing, your lifestyle through modifiable risk factors.
Fantastic. So I think so many of us tonight know someone, as I do in my family, with a diagnosis. We're going to hear about many of the things we're going to say can reduce risk of dementia, also can delay deterioration or onset of dementia. That's really right, isn't it?
Yes, it may. Look, one point to remember with all of this is we're talking about averages. So, I'm an academic and we're looking at big data sets and averages. And there are people who will develop dementia despite having a healthy lifestyle. It's a bit like smoking and lung cancer, where we know some people who don't smoke develop lung cancer. But what we say is if the population adopt all of these healthy lifestyle and factors and treat vascular risk factors, overall, we will reduce our risk and delay onset.
So healthy lifestyle, the 2 or 3 key things you really ought to do if you're trying to reduce your risk of dementia.
Look, it depends a bit on your age. In middle age, being physically active and manage your chronic disease risk factors and have a healthy diet. In later life, all of those things are important, but what really is coming out is social engagement is really important for older adults. Staying socially active and engaged and cognitively stimulated. They're the 2 things.
And do we know why social engagement? Explain what, like when I go to my local shopping mall at lunchtime, I live in in Adelaide, in the outer suburbs of Adelaide. There are packs of people with grey hair chatting around tables of 12 who've all just done some form of physical exercise. And I think if you go to most shopping malls, you'll meet that crowd. So what is it about the combination of physical exercise and that post-chatting that will actually reduce your risk of getting dementia or delay its onset?
Look, at a biological level, we don't fully understand the mechanism of how social engagement protects people from cognitive decline. And also the reverse, so loneliness increases the risk. But we know that it's very, very powerful. So loneliness is associated with all sorts of other health outcomes, not just dementia. But it's even shown in animal studies that, animals that are kept on their own and not interacting with family and other animals have poorer health outcomes. So it is something hardwired into us. And there are a number of theories about stress hormones and things trying to sort of around the biology, but we don't really understand sort of the science yet underpinning the benefits, but we know it's a very robust effect. We've seen it now in many studies.
And avoiding social withdrawal, that's slightly different from loneliness. What do you mean by social withdrawal, and how do you avoid it? What do you mean?
Look, these are somewhat subjective concepts too, because loneliness is a subjective thing. Some people could have a lot of friends and feel lonely. Another person may have one friend and not feel lonely. So loneliness is really how you feel, whether you report that you're lonely, and that's all we can really go on. We do see, you're talking about social withdrawal. I mean, sometimes when people have cognitive or start to be concerned about their cognition and start to have some memory problems, they start to stop engaging socially because they're concerned about that. And that can, you know, whereas the social engagement is really good, it's good for their mental health, but it's also good for their cognition. So I guess that's where social withdrawal is not ideal.
And the last thing I just want to ask you before I might welcome a family member to our screen is, you think it's critical as a community that we avoid stigma. How is that relevant to reducing the level of dementia in the population?
It's such a big question, really. Look, stigma, I mean, there's all sorts of stigma. There's stigma around the whole concept of dementia, around ourselves as carers. The problem with stigma is it stops people from, it's for the person living with dementia, and that stops them participating in daily life in a normal way like everybody else. It can mean people aren't seeking help and services. It's really a human rights issue as well. People are being denied the right to the normal participation and engagement and a job and income, all sorts of things that could go with it. So it's a big problem. And when stigma is addressed, we have better health outcomes for people with dementia, better for society all round.
Look, thank you so much, Kaarin. And I'm just going to hear, if I may, from Keri Kitay, whose late mother was diagnosed with Alzheimer's, and she's written a book, The Long Goodbye, Lessons on Humanity from the Grips of Alzheimer's. And Keri is an ambassador for the Centre for Healthy Brain Ageing at the University of New South Wales, what we think of as Henry's spot. And a big welcome to you, Keri. What have you been thinking about as you listen to them speaking? It must be still emotional for you, is it, to think about your late mother when you hear this sort of discussion?
Yeah, definitely. I think, there's always an underlying sense of sadness in our family about, having witnessed my mum battle her journey with Alzheimer's for, 8 years and a couple of years before that leading to the diagnosis. And I think one of the, you talk about stigma, and that's one of the key things that stood out to me throughout our journey was, I think, my mom being so young, being diagnosed at the age of 54, having, that younger onset dementia, and no one, not us, nor our friends or family or anyone really understanding, what that meant for my mom and how her life would then change. And I think through no fault of anyone other than none of us really being educated knew how to interact with a person who has dementia, and how do you treat them in society and not, stop engaging with them. And I think that's something that, was really hard for us as a family to witness and see my mom withdrawing herself from society and social interactions, because she knew that things were different. And she, as Henry was talking about, she developed what we thought was depression initially, but it was actually like the early signs of dementia. And so herself withdrawing and then just being withdrawn from society because she couldn't sit around a group of, with a group of friends or our family and participate in a conversation when her sequencing became all, mixed up and she couldn't follow conversations. And so naturally she withdrew. And I think for me and our experience, one of the most important things, there's so many, is that we do learn how to engage and treat people who do have dementia, and how they can still, and focus on the things that they can do, and that they can still be a really valued person in society.
And give us some example, because I know one of the key messages you want to communicate, and I'm acutely aware we have a number of people with a diagnosis with us tonight, as well as family members, but you and your brothers learned that you needed to be particularly active in involving your mother in family activities and finding the things she enjoyed and had always enjoyed, and supporting her to do that, and to include her. Can you give us some examples of the sort of things that you did to keep your mother socially connected to the family?
Yeah, absolutely. Like we started to focus on the things that she could do. So, she played tennis growing up. And so that was something she was still able to do. So we would go out, once a week as a family and play tennis together until she couldn't do that anymore. And we would, she knew how to knit. So we would get some wool and she would do knitting until she got to a point where she could no longer cast on and off. But for everything that she could do, we made sure that when we sat around the dinner table with my mom, that we spoke to her and included her in the conversation. And we were really conscious of involving her rather than us just talking amongst herself and her being left out of the conversation. We found things that she could do. She knew she could paint. So we got, people to come in and paint with her. And we just really focused on things that she could do and made sure that she was part of us when it came to birthdays and celebrations, especially when she moved into a care facility and was no longer living at home. We made sure that we didn't do those things without her. We involved her. We would take the celebrations to her and we would just change them so that she could be involved in those celebrations and family events. And rather than, she loved to be in the kitchen, but she got to a point where she couldn't follow a recipe. So rather than us taking over those kitchen duties and cooking, which was, the kitchen was really her domain, and she made us very aware of that, we would go and help her, like aid her to do things, but really just empower her to do them and let her do them and just kind of assist without kind of taking over from her. So we just had to we learned a lot on the go, and we did a lot of things wrong and we made a lot of mistakes, but we also just learned to the way that we spoke to her was different. We never put her in situations which challenged her. And I think we had to learn in some way a whole new verbiage and way of speaking to my mom.
Thank you so much. And I'm going to bring you back in, but I'd like to invite Dr. Lena Safro to come on with some audience questions. And if I could ask Nat, our media man, to bring all the panel onto the screen, including Dr. Anita Nitchingham, whom I haven't introduced you to yet, a geriatrician at Wolper and at Prince of Wales Hospital, and a conjoint lecturer at UNSW, and also doing a PhD on delirium. And I will come to you after our question time, but welcome, Lena. Can we have, if you could pop your mic on and tell us a question from the audience, please. You're on silent, Lena. Your mic? Great.
Can you hear me now?
Yep.
Oh, lovely. So there are quite a few questions to do with risk factors still, which is where you started, Julie, but to do with various medical conditions, whether or not there is a link to dementia. So insomnia, Parkinson's disease, ADHD. Are there any specific risks between those conditions and the risk of dementia?
Do you want to start, Henry, and then I'll come to you, Anita?
Yeah, sure. There is a link with sleep. It may go both ways, which I'll explain in a moment. It wasn't one of the 14 listed in the Lancet Commission I mentioned, mainly because there wasn't enough evidence. But there's lots of evidence that people who sleep less than 7 hours at night, or people who sleep more than 9 hours, have a slightly increased risk. The fly in that ointment is something called reverse causality. So it may be people who are developing dementia or having the pathological changes. Those things interfere with sleep. So it may be the dementia causing the sleep disturbance rather than the sleep disturbance causing the sleep. And it's hard to disentangle those. There are many people who sleep much less than 7 hours every night and function well and don't develop dementia. And I'd just like to point out something for the audience, the difference between relative risk and absolute risk. Let me give you an example. If I told you that eating kiwi fruit 6 nights a week increased your risk of a certain cancer from 1 in a million to 2 in a million, I could say it gives you a 100% increase in risk. That's a relative risk. But the actual risk is an extra 1 in a million, which is nothing. And so, and by the way, kiwi fruit's quite good for you, so don't get upset about that. And so the relative risk for sleep disturbance may be significant. The absolute risk, and for many of the things we're talking about, like type 2 diabetes or midlife obesity or high blood pressure, many of us have these things, but doesn't mean we're going to get dementia. It increases the risk. And as Kaarin has explained, we're looking at populations. It's on the average. As far as Parkinson's people often get dementia, and particularly as it comes on later in life. There was one study that I was somewhat involved with, where he calculated that over 70% of people who develop Parkinson's after the age of 70 develop dementia. And Parkinson's is on a spectrum with another type of dementia called Lewy body dementia. In Lewy body dementia, the same sort of pathology happens in the brain, but it starts on the surface of the brain, the cortex. Whereas in Parkinson's disease, it starts deep in the brain, substantia nigra, and then spreads out. But if you look at the brains of people with Parkinson's and Lewy body, there's a coming together. And many people with Lewy body get Parkinson's symptoms as the disease progresses, and many people with Parkinson's do develop dementia. I don't know enough about ADHD, and maybe Kaarin or Anita might know more about that, but I haven't seen any evidence about that. There is some evidence about childhood abuse being a risk factor, but it's pretty soft evidence so far, as I know.
Could I invite Dr. Anita Nitchingham to join us on this? I wonder if you could just mention some of your interest in delirium and the connection to dementia. I'm just aware we have quite an older group with us tonight, and I'm assuming age is a risk factor for delirium, but if you could explain what delirium is and your reflections on its possible link to dementia.
Yeah, sure. So I work as a geriatrician at the Prince of Wales Hospital at Wolper, and so we see a lot of acutely unwell people, and therefore we see a lot of delirium. So actually delirium will affect about 1 in 4 people aged over 65 that are admitted to hospital. Either they'll present to hospital with delirium, or they'll develop delirium at some point during their hospital stay or after an operation. And I describe delirium as acute brain failure. So it's really when you've got an underlying medical problem, maybe a medication, maybe a trauma of going through surgery, and it's putting pressure on your brain, and you have a decompensated state of brain function. And that can present in a number of different ways. Some people, it may be very obvious. For a lot of us, when we think about delirium, we think about somebody that might be actively hallucinating and running around, people quite paranoid. But for a lot more patients, delirium is actually hypoactive delirium, where people are quite withdrawn, they may be quite sleepy, they may just be less responsive than usual. People may be not eating and drinking, their walking may be affected. So if your brain is not functioning properly, then really everything is not functioning properly, and so it's a really risky problem to have in hospital. And often to manage and treat delirium, we treat the underlying medical cause. So a lot of the time people would be aware it's a UTI, but actually there are many, many other medical causes for delirium, and our job is to identify the cause and to treat the underlying medical cause. And for a lot of people, they recover back to their usual state, and that can happen within hours or days. But what a lot of people might have seen if you've had a family member with delirium is that they may take quite a long time to recover, even though you've treated the underlying medical cause. And some people may not quite recover to their previous cognitive baseline. And we know that people that develop delirium in hospital have a much higher risk of developing dementia in the future. And people living with dementia are much more likely to get delirium in hospital. So again, it's this kind of circle of what's causing what. But because we know in hospital we can prevent delirium, there's a thought that maybe if we can prevent delirium, we can reduce the risk of dementia. So maybe there's some brain injury going on.
And Anita, am I right in thinking that family can be very important to clinicians like yourself in alerting people that mum or dad are different from normal? Because of course you're often meeting people for the first time. Yes, absolutely. So we really have to work together with family members from the get-go when people are admitted to hospital to understand, if they're their usual selves or if people are not quite their usual selves. And then it's really important for family to be involved with the care in hospital as much as possible. Particularly for people living with dementia, it can be a very confronting experience to suddenly be, in hospital with a lot of people that are, trying to put cannulas in and tell you what to do, and you might not have understanding of that. And having familiar faces around to help reorientate is essential for delirium care. Just before we go to our next question, I know you're keen to talk about, as a working geriatrician, the management of cardiovascular risk. Can you just tell us what you mean by that and why that's important in terms of reducing the risk of dementia? Yeah, well, I think in terms of all the risk factors that we've discussed, there is pretty good evidence that
you know, reducing particularly blood pressure and getting tighter control of blood pressure can improve cognitive outcomes. So I think that it's important, you know, if we're thinking about how to reduce our risk factors, that we should really proactively try and see a GP, because you won't have symptoms of high blood pressure, you won't have symptoms of, you know, high glucose and things like that. So to proactively go see the GP and try and get your vascular risk factors under control. And of course, all of these things have great benefits for the rest of your health as well, in terms of reducing your stroke risk, reducing your risk of having a heart attack and things like that.
Thank you. I'm coming to you, Lena, as a working GP. There's something called a heart check you can ask for, isn't it, where all of that can be done?
Yes, you can.
Could we have another question, please?
Sure. So still on the associations between dementia and medical conditions, are there any links with gut health and dementia and vitamin B6 levels and the risk of dementia?
Henry? Oh, you're not on, Doug?
This is a very hot area of research, not literally as well as metaphorically. It's people have been looking at the microbiome. There's certainly a link between what's in our gut and in our brain and vice versa. And there have been studies looking at saying that our microbiome might influence our cognition and may influence our risk. I'm afraid I don't know the research well enough to be able to cite the examples for that. But there is also something, one of the questions I saw on the Q&A was about MHTFR, a gene, an enzyme that is important for homocysteine. And homocysteine at one stage was called the new cholesterol, and people with high homocysteine levels were thought to have a higher rate of cognitive decline and a higher risk. And that there was quite a flurry of research about that a decade ago. Things have gone quiet on that. And there's no evidence that reducing homocysteine actually does reduce the risk of dementia. But it's something that has had some interest in the past. And again, sorry, I was going to suggest Kaarin may have some more information there too. Yeah.
Kaarin, I did want to come to you about your risk assessment tools and interventions, but would you like to comment on anything that's just been said first?
No, just to echo Henry, that it's a very active area of research, but at the moment there is no evidence, you know, about or recommendations that could be made about gut health and risk of dementia.
Can you tell us what your risk assessment tools are and whether they're available, and if you do what you discover through that assessment tool and how you can reduce your risk if something's discovered?
Yeah, thanks. So we developed an online risk assessment tool that's free. It's on the website at Neuroscience Research Australia. It's called CogD-Risk, and it's based on a very large amount of research where we synthesized hundreds of articles to look at the risk, the relative risk, as Henry said, of the key risk factors. And then we've got standardized questions that have all been for measures that are linked to dementia risk. So you can go online, you can fill in the questionnaire, and it will then give you a report which outlines areas where you're doing well and areas where you could improve and reduce your risk of dementia. And in that report, it also links you to all of things like the national guidelines for physical activity, alcohol consumption, etc. So you can get the accurate information on how much you should be doing. And you can also take that report to your GP and discuss it with them.
Can you just repeat where people can find that assessment tool?
It's called CogD-Risk. CogDrisk. So if you Google that, you'll come up with it. It's at Neuroscience Research Australia. I think it's cogdrisk.neuro.au. I'm not sure of the URL, but I think it's going to be added to the website. Yeah.
Okay, fantastic. And I might ask the Wolper team when they send out their evaluation feedback form to put that link, because it sounds interesting. If I could come to you, Dr. Anita Nitchingham, because you're a working geriatrician, I think one of the points you wanted to make was that when you're seeing a patient and their family, you very much tailor your advice to the individual. And that's true also with exercise, because there isn't a Wolper Wellbeing Forum where we aren't told that exercise will help. But could you speak directly to what you do with patients around exercise, particularly older patients?
Well, I think you can hear from everybody that exercise is absolutely essential. I mean, obviously it depends on the patient. I'm such a geriatrician that I have to tailor everything, but I really feel that exercise has so many benefits in terms of course, your cardiovascular risk, but of course, socializing and things like that. So if you're around Wolper, you'll see people that have done the move well, and they'll be having a coffee afterwards. So there's so many other benefits beyond just the physical exercise. But I think that we have to be mindful that not everybody can do strenuous cardiovascular exercise on a treadmill or maybe even on a static bike. And there may be other exercises they may do, like Pilates and yoga and things like that. And so I usually refer people to the Active and Healthy New South Wales website. So Wolper has a number of programs as well, but the Active and Healthy website is across New South Wales, and it has tailored exercise programs that are age appropriate, so for older people, and they have it per postcode. So you can put in your postcode and you can see what exercise programs are around your area.
And I think you're interested too in reducing falls risk and frailty. And that's also linked to the capacity to keep exercising and reducing your dementia risk. Would that be right?
Yeah, that's right. That's right. So, I mean, they're all very much linked. But yes, if you do exercise, there's good evidence that you can reduce your risk of falls, particularly lower limb strength and balance training, and as well with frailty as well. So you can build up your lower limb strength and maintain your kind of mobility.
I think you also want to emphasize the need for a good assessment. What does that mean, a good assessment, and why is it important?
A general good assessment I mean, when you see a geriatrician, you get a comprehensive assessment, which means that you go through somebody's cognition, mood, continence, gait, diet, weight loss. We go through all of these things in a very comprehensive manner because they're all related to aging, and they all kind of interplay each other. And when you get older, you often are prescribed many different medications, and you need somebody to go through those medications with you to determine which medications are helping you and which medications are hindering you, because medications you might have been prescribed when you were 50 or 60 will have a different effect on your brain when you're 80 or 90, and a different effect on your body. So it's really important to have a comprehensive assessment to go through. And often we have a prescribing cascade where you're prescribed medications and they actually give you side effects, and then you'll prescribe more medications to treat those side effects, and then on and on we go. So that's why a comprehensive assessment is essential.
I'm going to bring on in a moment someone from Wolper who's running a healthy exercise and brain program. But Lena, would I be right in thinking there's an interest in the audience in what some of the new medications are that may be available? I think we had some interest in that. I might come to Professor Brodaty if that's okay. Henry, what's the story about medications? When can they help? And are there new medications we're soon to have access to in Australia?
The medications are specifically for Alzheimer's disease, the most common form of dementia. The ones that have been around since about 2000 are of a class of drugs called cholinesterase inhibitors. The way they work is they block an enzyme that destroys a chemical in the brain that's important for memory called acetylcholine. And these are drugs like Aricept, Exelon, or Remedal. And they've been around for a long time, and they're symptomatic. They don't treat the underlying cause. They try and replace or boost one of the chemicals that is most deficient in Alzheimer's. And there's another one called Ebixa or memantine, which is used for more severe Alzheimer's. Again, it's symptomatic. What's new and is coming and is available in the US, in China, Korea, in Japan and Israel, and these are the new monoclonal antibodies, and they attack the toxic protein, or what the toxic protein makes, called protofibrils or fibrils in the brain, and they remove it from the brain. So these trials were done over 18 months, and there have 3 been approved. One's been withdrawn since, so there are 2 been approved in the US. And they're before the TGA in Australia now, waiting for approval. And they're not cures. They do get rid of the abnormal protein from the brain, but it builds up again if you stop it. People do decline, but 27% less than the people on placebo. And they also decline less in their function and in a general measure of severity of dementia. The downside is they've got side effects. People get brain swelling and microhemorrhages. About up to 30% of people will get those. Most of that is asymptomatic. Curiously, quite a percentage of people on placebo get the same side effects, but less than half the rate in. So it was interesting for me that 17% of people on the drug got microhemorrhages, which are like pinpoint, and they resolve spontaneously. 9% of placebo did as well. So we get these changes in our brain all the time, and they resolve. And for most people, they resolve spontaneously. But for some people, they're more severe, and 3 people in the trial died of a hemorrhage. And that's, of course, a terrible outcome. But we know now that people who are on anticoagulants or have this genotype that Kaarin mentioned, that a quarter of us have an E4 variety of this gene. Most of us are E3, but having 1 copy of E4 or 2 copies of E4 particularly, 2 copies makes you much more liable to have these hemorrhages. Although a number of people in the trials were homozygous, they had E4 and didn't get the hemorrhages. So the third side effect is financial. The cost is $26,000 a year, or 40,000 Australian dollars. If the TGA approve it, who knows whether the PBS will subsidise it. If it doesn't, it'll be for the rich. The UK has just approved the first of the drugs, lecanemab or Leqembi. But the NICE, the National Institute for Clinical Excellence, has said it's not worth the money to subsidise it. So it's approved, but most people won't be able to afford it. And we don't know what's going to happen in Australia yet. In the US, Medicare has approved it. I'm not sure what's happening in the other countries. But it's a game changer. These are new. It's the first time we've had disease-modifying drugs. And there are others on the market. There's also been some publications recently about some of the new diabetes drugs having some protective effects. So like Ozempic even. We don't have proper trials yet on that. And some of the other ones, the ones that work through the kidney, I forget what the names of them are. So, Anita probably know better than me. And so there's a big study came out of Korea just about a week ago in the British Medical Journal showing that that drug, SLG, I've forgotten the acronym for that, did show quite a significant reduction. These are people with diabetes treated with that drug versus another drug had about a 35% reduction in the risk of dementia over at least, and the longer they're on it, the better. Yeah.
Look, thank you, Henry. Anita Nitchingham, would you like to comment on these, new medications that are on the horizon from a treating clinician's point of view?
Yes, I think it's very exciting, but I'm very cautiously optimistic. I think there might be a place for them in a younger cohort with a very whether it's very clear that it's Alzheimer's disease dementia. That's the key thing here. But when people are older and in their 80s, usually when I see them, it's often mixed pathology in dementia. So it's not just clearly Alzheimer's, it's not just clearly vascular, it's multiple problems. And so I'm not sure that cohort is going to be, I don't think they're going to be the cohort that we were receiving these drugs. And I think we also have to be mindful that they were able to remove a lot of amyloid from the brain, which is great because we think that is part of the reason people are getting Alzheimer's. But whether the changes we saw were clinically significant, so there was a lot of great statistically significant changes, but the clinical significance on those changes are a little bit more questionable, but maybe over time we'll see greater and greater clinical significance. So
And
but they were doing kind of scores of people from 1 to 140 on a test, and that, you know, they were showing a change of maybe 2 points, and whether that's a clinical significance is arguable. That's all. But I think I'm excited for them still.
I just wanted to clarify, in your world, you're saying they may be helpful for younger people. What's younger to you? What age do you mean?
Well, I think I mean, and also there's some other contraindications and things like that. But I think it would be more kind of the less than 75s, or where it's very, very clearly, so there's clear diagnostic criteria for Alzheimer's disease. And so for people that reach that criteria, which means getting specific scans, biomarkers, that kind of thing, then they'll be appropriate. But most of the people that we see tend to have much more mixed disease. So I'm not sure that those medications are going to be of benefit to a lot of people, but maybe to around 10% of people diagnosed.
Look, thank you. And Henry, you wanted to comment.
Yes, another caveat is for people with very mild disease. If people had already significant dementia, it's not going to be any use to them. It's too late. And in fact, I think 2/3 of the population didn't even have dementia. They had mild cognitive impairment, which is, remember, there were 2 elements to the definition of dementia: cognitive decline and functional decline. They had some cognitive problems, but they were functioning quite well. But they were able to show they had the Alzheimer's pathology with the new PET scans, which can actually show the amyloid, or doing lumbar punctures or spinal taps to examine the cerebrospinal fluid and show the protein configuration there. So once people have already got dementia and it's interfering with their life, it's going to be too late. So it's not going to be a cure for everybody. It's not going to be for everybody. And we know, as Anita was saying, the older the person is after the age of 80, the more types of pathology accumulate. And it's rare to have single pathology at post-mortem in people, say, 85 years old.
Ladies and gentlemen and everyone, what I'm going to do now is to invite Dr. Weihong Zhang onto our screens to talk about a program at Wolper Jewish Hospital, and then I'll return solely to your questions for the rest of our webinar. But welcome, Weihong. Weihong is an occupational therapist and a lecturer at the University of Sydney in the School of Health Sciences. Her PhD was in gait, cognition and falls, and she runs the Healthy Mind, Healthy Body program at Wolper. Welcome to you. Can you tell us who's eligible to join the program, and then what do you do that helps people reduce the risk of dementia?
Right. Okay, great. Thank you for having me. So this program we developed with Wolper Jewish Hospital, myself and also the geriatricians. Dr. Nitchingham was also involved in that one, and Dr. Nick Mills, and also a collection of the healthcare professionals working at Wolper Hospital. So the program is an outpatient program. So it's running for 12 weeks, once a week, 3 hours. So we're covering multi-component. So all the risk factors we just talked about, like to exercise, reduce the risk of vascular health, say for example, healthy eating, mindfulness practice, and also like social interaction. We promote that one as well. And we do a series of education topics, for example, like sleep and health, and also yoga, which is a mind-body connection kind of exercises. We're trying to putting all this together and give it to the community. So the eligibility criteria is anyone 65 and above, as long as they are able to mobilize independently and do exercises for 15 minutes without the risk, so they are able to come to the program. So we do screening for the cognition, like Henry and Anita was saying. We try to target the population a bit early. So at the early signs, if they started to feel, oh, I'm getting a bit forgetful, or they feel I'm slowing down compared to my younger self. And also we have a lot of participants that are coming in, they're actually intact. They can score 30 out of 30 on the MOCA that when Henry just mentioned about. So they want to be more proactive and getting this lifestyle change and to maintain and improve their function as well. So we have already run 3 terms of the program, so 12 weeks. So the age of the participants so far is from 69 79 to 86. So what we're trying to say is it's never too late for anyone to come to join the group and promote a healthy lifestyle.
And you also think it's never too early.
Yeah, I did say that. I think the doctors, they have already mentioned about, a lot of the things we can to reduce the risk of having dementia is from like midlife, 40s and 50s. So like address your hypertension, the blood pressure issues, the cholesterol issues, all this vascular health. So the earlier you're, adopting a lifestyle change, the better you benefit for, for your life, and also you can live longer and healthier. Because I'm doing teaching in the university as well. So I do part of the teaching, I'm educating my students, they're in their 20s. I say, okay, you need to make sure you sleep well and make sure you're, ensure your mental health and do the exercises. Even that younger age, I do say you need to, adopt a healthy lifestyle from very early on. So it's never too early. The earlier, the longer you're having a healthy lifestyle, the better you'll benefit in your life.
Thank you so much, Weihong. And I might welcome Keri Kitay back to the screen, who's written the book, The Long Goodbye, Lessons on Humanity from the Grips of Alzheimer's, telling her mum's story. Keri, I was interested in, what you're doing. You've witnessed Alzheimer's up close. What I think, can you mind telling us your age and what are you doing at your age to reduce your risk?
Yeah, of course. I'm 40 and I was in my 20s when my mom was diagnosed, and we learned pretty quickly that although my mom was quite advanced by the time she was diagnosed, we learned very quickly around, exercise and diet and social interaction and all those things. And I come from a very sporty family, so exercise and physical activity was very much ingrained in our daily lives. But for me now, and for as long as I can remember, that is a daily non-negotiable. That's something that I do every single day, and it doesn't always have to be extremely vigorous. It could, on the weekend, it could just be a walk. And I do mix between going to the gym and doing strength training, as well as like Pilates and doing something fun as well, like playing a sport. So something I picked up, during COVID times was my tennis racket again. And that's something now that I do. So it's both. I feel like even though I learned to play tennis at a young age, I'm relearning how to play tennis. So I feel like I'm constantly looking at ways to be active, but also learning new skills. Just in terms of like diet as well, and just nutrition, that's something that I'm really conscious of, about what I put in and on my body. So making sure that I just always eat fresh and healthy food, and not completely strict 100% of the time. I think it's also important that we do enjoy life. And I think that social interaction is something that I've heard Henry speak about for 12 years that I've known him now. And it's something that's really stuck with me, and I see it being so beneficial. So yeah, just being really social and constantly making time to meet with people, friends, and my work is really social. So I think I get a lot of social interaction, but more so like meaningful social interactions. So I think those are some of the non-negotiables that are now just a sustainable part of how I live my life.
Hey, look, just before I come to our questions, the early signs that something was happening to your mum that at the time you didn't realize. Can you just share a couple of those examples?
Yeah, so one of the first things when we go back in time and, in hindsight, was that my mom became really withdrawn from her friends, from us, from being social, doing the things that she used to love to do. She just stopped doing all those things, and we thought she was actually depressed. She was just not her usual self, not her social bubbly self. And then things that, just simple tasks that she had been doing her whole life, like, was forgetting where she would just forget where she had put things, like as simple as her keys, or she would forget how to follow a recipe, or she would often cook without using a recipe and could no longer do that anymore. And she just simple tasks. She would work with my dad in his dental practice, and she would do booking appointments and taking payments, and all of those things that she had done for 15 plus years, she just couldn't do them anymore. She was making mistakes with the bookkeeping and everything. And so all these things were happening, but they didn't happen all the time. They would happen, and some things happened in isolation where she would forget something or lose her car in a car park. And I know that's something that we all do, but when that happened to her and I was with her at the time, it was different. And I think you talk about like someone becoming really anxious, and I saw a side to my mom that I had never ever seen before. And although that was an isolated incident, you know, looking back in hindsight, that was a really big tell. And that was probably something that I should have been more concerned about, but didn't know at the time. So there was just an accumulation of things that happened over about a year and a half, where lots of things were happening, which were unusual behavior for her, and specifically around her confidence, and then just not wanting to drive anymore and making excuses for not wanting to do the things that she would ordinarily do so effortlessly.
Thank you so much. It's so great. There's nothing like hearing real personal stories. And I just want to thank you on behalf of everyone that you do this at work as an ambassador for Henry. Henry, I just want to say, I know there are people watching this who are thinking, I can very rarely remember where I parked the car, particularly at the airport when I fly back in. I'm always looking for my keys. I know this is a hard question, but the difference between common ordinary forgetfulness that does often increase with age and something's wrong, I need an assessment.
Well, one of the things people used to say, it's not just forgetting who sat next to you at the dinner you went to last night, but being at the dinner last night. So forgetting the whole event rather than the detail, it would be one thing. And as I said before, if it's starting to invade other areas, like you making mistakes when you're doing your finances, as Keri's mother may have been doing with the billing for her husband, or things that are uncharacteristic for you. And if other people's notice, then I would do that. And you may have heard that there's been legislation, this is something that affects me, the doctors after the age of 70 are going to have assessments every 3 years to keep their license going. And part of that's going to be a cognitive assessment, because that's the thing that's most worrying about doctors like me, who's well over 70 now, you know, still working. Then how do we do that? And that's going, well, that's a whole separate other talk, but it's going to be a big issue.
Yeah, absolutely.
Yeah.
Lena, could we come to more audience questions, please?
Sure. So there are quite a few questions still on specific risks related to the risk of dementia. Things like repeated general anesthesia for surgical procedures and the use of sleeping tablets. Do these things increase the risk of developing dementia?
I might come to Anita Nitchingham. How would you answer those questions?
There's not strong evidence that general anaesthetics themselves increase the risk of dementia. We don't have much evidence to support that. But there is evidence that delirium is associated with dementia. We can't necessarily predict who will get delirium, though the risk factors for delirium are the same as the risk factors for dementia. And there are things you can do to reduce your risk of having a delirium after an operation. They include reducing the amount of fasting time you have, so your surgeon and anaesthetist will probably help you with that. Sometimes the anaesthetist can monitor the depth of anesthesia, so how much drug they're giving, and there's a little bit of evidence that might reduce your risk of post-operative delirium. But in terms of the relationship between just general anesthetic and dementia, there's not that evidence yet. And sleeping tablets, there's an association, but I don't think there's a causation. So I don't think you could say that taking sleeping tablets causes dementia, but certainly we know that sleeping tablets can affect your cognitive function and increase your risk of falls when you get older. And I really would try to recommend reducing them or trying to avoid them. I wouldn't recommend starting them. And you should never abruptly stop taking sleeping tablets. You should always speak to your doctor because your brain gets used to them and they need to be weaned slowly. So yes, there's not a direct risk, but there are risks of taking them when you get older.
Thank you so much. Henry, would you add anything there?
Well, I agree with what Anita's saying. With the sleeping tablets, you know, because you're not sleeping 7 hours a night doesn't mean you take sleeping tablets to get into that 7-9 window. That's the wrong way to go. and sleeping tablets can make you more confused and certainly increase your risk of falls. So I wouldn't be doing that way. Yeah.
Kaarin, did you want to comment on anything we've been talking about in relation to these health conditions and reducing risk?
No, I think it's been really well covered.
Okay, thank you. Another question, Lena?
Sure. Still on reducing the risk. Someone is asking about using weights and resistance training. They read somewhere this was particularly good in helping to prevent dementia. Is this true?
I could just jump in there. I mean, I'm not involved in the program, but maybe Weihong might want to. But Maria Fiataroni-Singh, who's at Sydney University, has done quite a lot of research on this. And she's very strong that weights is probably even more important than aerobics. And so resistance training or weights, perhaps combined with aerobic training and balance training, is best of all. But doing some strength training, at least 2 days a week, is what's recommended in the guidelines, plus the number of minutes per week or per day or so on. Yeah. Of moderate to vigorous intensity. It can't be just a stroll with your friend around the park chatting. Doesn't really do very much. You have to pick up the pace.
Okay. Weihong, would you like to comment?
Yeah, so for example, the exercise program we included in the Healthy Mind, Healthy Body is we include 3 different types of exercises. That's aerobic exercise, balance, and strength. So Henry was talking about resistance is the strength exercises. So all 3 different types of exercises really good for your brain health and then body function as well. So I would personally really not just myself, but the whole team. And Anita, you can comment on that one. So the aerobic exercise, I would say particularly really good for your vascular health and the brain health as well.
Can you explain what aerobic means, just in case?
Yeah, so when your exercise enough to bring up the heart rate and the respiratory, so there's more circulation to go into your brain as well to nourish your give the oxygen and nutrients into the brain cells. So that's really important. So there are criteria to reach. So what, like Henry was saying, it's not just having a stroll, have a window shopping. That's exercise. It's not hard enough. So we're actually really pushing your heart rate to the 60 to 80% of the maximum heart rate. So generally speaking, you can use like a formula like 220 minus your age, and then times either between 60% and 80% of that. So Henry was saying like the moderate to vigorous kind of exercise, we're trying to aim for that. So when you're doing at this level, and then enough circulation into the brain and really, really promoting your brain health. So yeah. So Anita, would you like to comment anything on that?
I don't have much more to comment on it. I think any exercise is excellent though. And the more that you do, the better it's going to be. So.
And I think, Anita, you've begun exercising more because you're constantly telling older people, so you've decided you better do it yourself. What do you do?
Yeah, I know. I've been telling older people to do exercise for about 8 years, and I wasn't really doing terribly much. I was having children though, so I use that as an excuse. But yeah, I've just started doing some Pilates. So I'm doing 2 hours a week of Pilates, and then I'm going to start doing some cardio hopefully soon. So we'll see how we go.
I'm a relatively new grandmother, and I can assure you that I think chasing children is exercise. I go to an exercise physiologist. He said, "What's your goal?" And I said, "To catch the grandchild and get up and down off the floor."
Yeah, that's right. Keeps me busy.
Sorry, I beg your pardon.
Just one more comment in terms of doing exercises. I know everyone is leading a very busy life, like Anita and Henry. Henry got the exercise back. He's onto it all the time. So when I was doing my falls prevention and doing my PhD program, and also my supervisor, Professor Lindy Clemson, and one of the sort of the research she's doing is to incorporate exercise into your everyday activity. For example, when you do the cooking, preparing meals, you can do a bit of a squats. You can, just bending your legs and doing some, heel rise and all these exercises. You don't have to go to the gym every day for 1 hour or 45 minutes. So you can, like say, park your car a little bit away from your work, and then you do that exercise and do the walking to work. Then that's part of the exercises. And do your housework and, do anything you have to do, but incorporate with some exercises.
Thank you. Lena, another question, please.
Sure. So If your doctor, your GP, and your specialist don't know where to get tested, who could help and what tests will provide a baseline risk and identify any individual risks of dementia?
Anita, could I come to you on that?
Yeah, sure. There's a number of different specialists that have an interest in dementia. I mean, obviously, most geriatricians or all geriatricians should be able to be very comfortable diagnosing dementia. Henry can probably talk to the older age psychiatrist because there are some that have interest in dementia. You can talk further to that. And there are some cognitive neurologists as well. In Australia, there's less neurologists interested in dementia, but there are certainly some. And if you're not sure, I would say a geriatrician or old age psychiatrist are probably the first place to start. And certainly you could send, if you're not sure privately, then publicly you could go through the public hospital system and you'll be triaged in an appropriate place.
Henry, would you like to comment?
Yeah, I completely agree. There are also some memory clinics around. There's one at Prince of Wales, but it's got quite a long waiting list. We used to run one at Prince of Wales ourselves for about 30 years, but we got closed down for financial reasons by the Department of Health. But, you can go to private doctors. And neurologists are pretty good at diagnosing things, but not all of them are interested in dementia. I think they're getting more interested now there are drugs coming out. But they usually are not that involved in continuing management. And so dementia is a journey, it goes on for many years. And different problems at different stages. So you want a specialist who you can build a relationship with and with the family that's going to be there over the years. And so a geriatrician or a psychogeriatrician, would be a good person to be involved with there. And there are plenty of people in private practice, particularly a lot of geriatricians are in private practice, not many psychogeriatricians. Yeah.
And if I could just say as a daughter, and I don't know if you want to comment, Keri, the great advantage of a geriatrician is that they do give that comprehensive overview. It's a bit like a pediatrician when you're young and then try to get a geriatrician when you're older. But from your experience as a family member, what did you find most helpful in terms of support for the family as well as for your mum?
Yeah, I think in our situation was a little bit different. When my mom was diagnosed, we really sought help from people in our community who helped us along the way and kind of guided us. And we had a whole host of people, from doctors to psychologists, that used to see my mom, and between my family and I and family friends and aunts and things, that became really integral in her care, from bringing in different carers and different people from like Jewish Care and different organizations to do that. So we sort of had like an army of people that came in for at various times. And as time progressed and her Alzheimer's got worse, we needed, her needs changed. And so often throughout those 8 years, the people that came in and cared, or when we went into homes, changed along the way as her needs changed. But I think from like a family point of view, it was really important that we stuck together and that we communicated. And while, predominantly my dad would look after my mom, it was about the rest of us looking after him and sort of looking after each other. And it absolutely can shock your family in the most unimaginable ways. And I think one of the things that we were told really early on is to get support for ourselves, as well as, my mom had her own psychologist and someone that she would see on a weekly basis. And we had to get that help as well, or just to, even in terms of like how to navigate the situation and our own feelings and emotions and everything that was changing for us. So I think from a family point of view, like getting the help that you need as much as the help as the person who has dementia.
Look, thank you so much. Lena, is there one more question? We're very close to finishing, but is there a question of significance you think we should bring forward?
There are lots of questions, but if I had to choose one, a lot has been written about neuroplasticity.
Yeah.
Can we have a comment in the framework of dementia management?
Thank you. Henry, can I come to you? Can you give us a definition of neuroplasticity and then how it links to everything we've been talking about tonight in a way?
The brain can keep developing. That's the plasticity part, that it's moldable. That's what plastic means. And we even have stem cells in our brain at a late age. Not as many, of course, as when we're younger, but there are still our stem cells. And the way memory works is we lay down like tracks And the more times you do something, the deeper the track and the more quickly the neurons can spread along there. And you know, with muscle memory, Keri's playing tennis, as she does it more often, the tennis will become more fluid. And when you're memorizing something more often, it sticks more longer. So there was a famous experiment done maybe 40 or 50 years ago in Brisbane. And this psychologist took a group of older people to learn German. And she showed that they could learn a new language in late life. And it's still possible. So it's harder, but it's still possible.
And you talk about reablement and cognitive rehabilitation.
Yeah, so we're very big on this. And of course, a lot of people around the world are doing this. See, after a stroke, people get rehab. After a diagnosis with dementia, people are told to get their affairs in order and nothing much happens. And of course, people with dementia can live a positive life for many years. And so the movement now is to try and, how do you support someone to do that? If you've got a bad leg, you get a crutch. If you've got a bad memory, you can have crutches for that too. You can have strategies or scaffolding to keep your brain working as well, to keep you able to do the activities you used to be able to do. So Keri said with the cooking for her mother, she didn't have the frontal lobes to organize to do all that. But people come in with her and she could start doing it. And so she's back in her domain. She feels useful. She feels proud. And it changes her whole outlook. So it's us to be creative and to help the person do the things they want to do. And not just, I hate the word demented because it sounds like you're not demented or you are demented. But it's a gradual process. And just because parts of the brain aren't working, other parts are working really well. And we need to build on the positive and compensate for the negative.
Look, absolutely brilliant. I've got 1 minute. I just want to ask, if I may, Professor Kaarin Anstey, is there any point that you think we've missed that's really important?
Oh, I guess we haven't really talked about mental health, and that is another, risk factor for dementia is major depression. We know that. So I think, along with the healthy diet and physical activity, we also need to look after our mental health.
Okay, look, thank you. Thank you very much. Guys, we've reached the end of our time. So I just want to thank an amazing panel, I think you'll agree. Professor Henry Brodaty, Professor Kaarin Anstey, Dr. Anita Nitchingham, Dr. Weihong, Zhang, and also Keri, Kitay. And I'll just say the name of her book again, The Long Goodbye, Lessons on Humanity from the Grips of Alzheimer's. And I really want to thank also Lena Safro for monitoring our questions and also for her tender opening remarks at the beginning of our webinar. You will receive a feedback survey from Wolper Jewish Hospital. Please fill it in. They do look at them and take it all into consideration in the choice of topics and so on. And a reminder that this webinar has been recorded and will be available on the Wolper Jewish Hospital website. Our next webinar, as you can see now on the screen, is on Wednesday, the 6th of November, and the topic is the voluntary assisted dying laws. So Wednesday, the 6th of November. My name is Julie McCrossin, and it's been an absolute pleasure to be with you, and thank you for joining us this evening. Good night.